everyone. Hello, everyone. My name is Moises Agosto. I'm the Director of Treatment for NMAC, formerly known as the National Minority AIDS Council, and also I lead the HIV 50 Plus Strong and Healthy program. Today, we have a great session on aging with HIV. We have a we're very honored to have as a guest Dr. Scott Turner. He is a tenured professor in the Department of Neurology and the director of the Memory Disorders Program at Georgetown University in Washington, D.C. He received his doctorate and medical degrees from Emory University in Atlanta, Georgia, and followed by an internship in internal medicine and a residence in neurology, and a Howard Hughes Medical Institute sponsored fellowship in behavioral and cognitive neurology, all at the University of Pennsylvania, Philadelphia. Prior to moving to George Washington University, he was the chief of the neurology service at the VA and Harvard Healthcare System, and a tenured associate professor and associate chair in the Department of Neurology at the University of Michigan and Ann Arbor. He is also a board certified in psychiatry and neurology. He also directs the Memory Disorders Program and at the University of Georgetown, and his research focuses on development of new treatment and biomarkers for neurodegenerative dementias of aging, particularly for individuals with mild cognitive impairments and dementia due to Alzheimer's disease. He has published over 100 peer-reviewed papers, reviews, and book chapters. Dr. Turner is in the steering committee of the Alzheimer's Therapeutic Research Institute, and also he is a PI for NIH-funded Alzheimer's Clinical Trials Consortium. We're very honored to have him as a speaker. I also want to say thank you to our co-sponsors for this webinar series, which is the George Washington University, the DC CFAR. We are very grateful. And also, I think we have Brandy Robinson here to tell us a little bit about the George Washington University CFAR program. Do we have Brandy Robinson? Okay. So Dre, do we have the slides? Here is the slide. I was wondering if we could have Brandy. She's here. We can give her the opportunity to talk about the DCC-4.
I am looking for her in the
She's in the attendees. She's in the attendees.
I sent her the link to the to join as a panelist, and I'm going to resend it to her. I already resent it to her.
All right. Yeah, here she is. Great. Wonderful. Yeah.
Hello, everyone. Sorry about that. And I don't know why my screen is blurry. I was in the other Zoom, but thank you so much, Moises, for that introduction. My name is Brandy Robinson, and I am the Administrative Director of the DC Center for AIDS Research. And we are delighted to be co-sponsoring this event with NMAC. And just a little bit of background on the DC Center for AIDS Research. Okay. Mission is to advance our multi-institutional research effort to contribute to ending the HIV epidemic and improving the health and quality of life of persons with HIV in DC and beyond in partnership with community and government. And so I won't go through everything here, but you see these are our 9 collaborating organizations, and we currently have 260 investigator members. We support HIV science in DC through pilot programs and core services. We have a large and active community Partnership Council, excuse me, and we have community engagement and strategic planning, pilot awards, co-leads in scientific working groups, scientific interest groups, and the NCCC. Next slide. And so just some other background, there are a network of 20 CFARs that are funded by NIH, and you can see them on the map here. And we all support the mission of a multidisciplinary environment that promotes HIV research and prevention, detection, treatment of HIV infection and AIDS. And thank you again. Moises, you're on mute.
Thank you, Brandy. Happy to collaborate with you. All right, so I'll pass it to Dre, our Dr. Turner.
Someone needs to let me share my screen. Okay.
You can go for it.
All right. Well, thank you for the invitation. We're going to talk about neurocognitive challenges among older adults living with HIV. As mentioned, I'm a professor of neurology, director of the Memory Disorders Program at Georgetown. We're doing a lot of research on Alzheimer's disease, but in our clinic, we see patients with all sorts of memory problems. And so we're going to talk about HIV hand, HIV-associated neurocognitive decline, as well as MCI and dementia due to Alzheimer's disease, and talk about if there's any interaction or how they may overlap with each other. So how do you start? So I went to ChatGPT, I typed in a prompt and I said, is HIV a risk factor for Alzheimer's disease? And it came back with, yes, HIV is considered a potential risk factor for Alzheimer's and other forms of cognitive decline, although the relationship is complex and still being researched. So there's a lot of hand waving here. But then if you go further and it says clear evidence directly linking HIV infection to higher incidence of Alzheimer's is limited and inconclusive, which is more hand waving, and not yet definitively proven that HIV directly causes Alzheimer's, but it likely contributes to brain changes that can overlap with or accelerate Alzheimer's-like pathology. So basically all of this is saying we don't know. And we just don't know, and there's not enough data. So a patient came to my clinic several years ago who was a 71-year-old man with a 14-year history of HIV, diagnosed after presenting with flu-like symptoms and a viral pneumonia, treated with ART since then, and came with his wife, who said, yes, he's having short-term memory problems for 5 years, insidious onset, more noticeable decline in the last 3 years, comprehension difficulties, forgetting recent conversations, difficulty multitasking, took longer to complete projects, made mistakes, could no longer do his work as an attorney. So he was forced to leave work before he really wanted to and retire before he wanted to. He had trouble learning new skills, such as using his cell phone, calculations, challenging, spouse took over household finances. He remained socially active, exercised daily, enjoyed weekly religious services. There was no aggression, anxiety, agitation, hallucinations, delusions, paranoia, suicidal ideation. So he had had a stable HIV infection for 14 years, was very compliant with his ART, and these are the drugs that he was most recently been taking. No history of CNS infection, injury, stroke, TIA, alcohol, drug abuse. Mother died age 89 with probable Alzheimer's, and father died 71 with Parkinson's and dementia, which we would probably call Lewy body dementia today. On examination, he looked very healthy. His MMSE score was 22 out of 30, so this is in the range of mild dementia. The MoCA test, a little bit more difficult than the MMSE, also consistent with a mild dementia, got only 20 points out of 30. Recalled only 0 of 5 words on delayed recall, so clearly some memory difficulty. Difficulty with repetition, gave concrete answers to similarities. Only 7 words could be generated in 1 minute, starting with the letter F, so this is a marked decline from what we would expect from an attorney. Paragraph recall was only 5 out of 25 immediately and 2 out of 25 after 30 minutes. So clearly significant memory problems. He had 2 neuropsych evaluations 27 months apart, both consistent with dementia, and there was an interval decline in his scores between the 2 tests. And laboratory workup, normal, subnormal CD4 T cell count, depressed CD4 CD8 ratio, non-detectable HIV in plasma, and all other blood tests were normal. Spinal tap, spinal fluid revealed a low A beta 42 tau index consistent with Alzheimer's. An amyloid PET scan revealed uptake of the ligand in frontotemporal and parietal lobes. So these are 2 biomarkers in CSF and by imaging that are consistent with a diagnosis of Alzheimer's. And these are the results of his neuropsychologic testing. This was evaluation number 1, and then 27 months later, evaluation number 2. Evaluation number 1 is already less than expected and consistent with mild dementia, but in the intervening 27 months had a significant decline. For example, the Boston naming test, just naming 60 objects on 60 cards here, got 47 out of 60, and then 27 months later got only 40 out of 60. This is a significant deficit in a naming task, which is a language task. Here's working memory index went 50th percentile to 23rd percentile. So lots of scores went downhill, and both of these were consistent with dementia. And then he had some imaging studies. So first starting out with a glucose PET scan of the brain. So the brain takes up fluorodeoxyglucose from the blood when the brain cortex is active. And there were regions that were normal, especially some of these in the frontal cortex here, but there were areas of hypometabolism, particularly parietal and temporal, shown better here. These blue areas are areas of hypometabolism, meaning that the glucose is not being taken up from the blood because of diseased cortex. In this pattern, temporal parietal hypometabolism, this is kind of consistent with a diagnosis of Alzheimer's. But he also had a little bit of hypermetabolism in basal ganglia, which is something we see sometimes with hand. So the glucose PET scan was abnormal and showed some evidence of hand, but also some evidence of Alzheimer's disease. And this is a research study by Dr. Zhang Zhang looking at functional MRI connectivity in this individual. And these red areas are regions that are not as connected as they should be in a normal individual. So here's a graphical indication of that. Here's the normal controls, and here's Alzheimer's and mild cognitive impairment individuals. And here's our one case of decreased connectivity in a pattern that's sort of consistent with Alzheimer's and mild cognitive impairment. But the real clincher of the diagnosis was an amyloid PET scan. So this is a ligand that binds to amyloid plaques in the brain, and this was markedly positive. And there was a significant amount of uptake in the cortex of this individual, shown here, parietal and temporal, and some frontal uptake of the amyloid PET ligand. So this is a very positive amyloid PET scan and consistent with a diagnosis of Alzheimer's disease. So you've all seen graphs such as this. So this is the aging HIV population in the United States, and this was taken from this website in 2025. So now we have more than half of HIV positive individuals are over 50. And these are the numbers here, greater than 65. So now, people with HIV are starting to live longer, which is good, but now they're coming within striking distance of Alzheimer's disease because the major risk factor for Alzheimer's is aging. And somewhere between 2 to 5% of people at age 65 have Alzheimer's, and it approximately doubles every 5 years after that. So we probably would expect some of these older individuals to get Alzheimer's disease. The question is, would HIV impact that risk or not? So we do have this syndrome called HAND. So HIV alone can cause cognitive problems. Before more effective therapies, we actually saw more HIV dementia or HAD, HIV-associated dementia. Now with more effective therapies, we're seeing the milder forms, particularly this asymptomatic neurocognitive impairment and mild neurocognitive disorder are more commonly found in individuals who do have cognitive decline. Prevalence is maybe 30 to 50% of individuals with HIV have some cognitive decline. And of course, the harder you look, the more you would find cognitive deficits in older individuals with HIV, thought to be caused by direct and indirect effects of HIV on the central nervous system. And despite art, HAN continues to persist, but has evolved to the milder and more cortical forms of cognitive decline. So certainly has shifted over the years because of effective therapies. As far as the definitions, asymptomatic neurocognitive impairment, in my experience, ANI can be symptomatic. So I kind of take issue with this nomenclature. There's a decline in neuropsychologic testing, but no functional impairment. In neuropsych testing, one standard deviation below the mean and at least 2 of 5 cognitive domains on a neuropsych testing panel. So in the Alzheimer world, we would call this mild cognitive impairment or MCI. In the HIV world, it's called asymptomatic neurocognitive impairment, even though it may be symptomatic. And then a little bit more severe is MND or mild neurocognitive disorder. And the patient may not necessarily consider this mild. For example, our patient, when he could no longer work, certainly did not consider having to stop working as a mild symptom. But here's the nomenclature again, mild neurocognitive disorder, which, to me, calling these things asymptomatic and mild is sort of trivializing cognitive concerns and cognitive disorders in these individuals. But that's the terminology that we have. So now we're starting to get functional decline. So impairments in activities of daily living is required for this categorization of MND. And then there's the HIV-associated dementia, which is the more classic form of dementia from HIV, as seen back in the days when medications were not as effective. And basically anyone who saw this patient would have no difficulties in calling this patient dementia, with marked impairments in ADLs and at least 2 standard deviations below the mean in cognitive testing. But there's also this exclusionary clause, so that if there's evidence for another disease that causes cognitive decline, it's difficult or perhaps impossible if you strictly apply these to diagnose these disorders, ANI, MND, and HAND, if there's some other cause of disease. As far as Alzheimer's disease, I just pick on that because that's the most common cause of dementia in the older population in the US, just reached over 7 million in the US with Alzheimer's disease. The precursor is amnestic mild cognitive impairment, typically for Alzheimer's disease. Causes cognitive decline and then functional decline and lots of behavioral issues and changes, including depression and anxiety. There's a gradual and progressive decline in memory, language, executive function, and it's characterized by amyloid plaques and neurofibrillary tangles in brain tissue, which is associated with neuroinflammation in the brain. These are the most recent staging criteria for Alzheimer's disease. We have stage 0 of someone who has one of these rare autosomal dominant mutations that cause Alzheimer's, but they haven't reached the age where it starts to impact cognition. So this is called stage 0, where they have a gene mutation. So relatively rare, about 100 pedigrees in the world. Stage 1 is normal cognition, but biomarkers are becoming abnormal. Stage 2 is when cognitive impairment begins, but function is normal. Stage 3, cognitive and early functional impairment, and then 4, 5, and 6 are with mild, moderate, and severe functional impairment. And again, we have this clause that other causes of dementia must be excluded. And so, we're sort of painting ourselves into a corner a little bit here. We've now, in recent years, developed a lot of good biomarkers for Alzheimer's disease. Some of these are looking in proteins in spinal fluid or plasma, and some of these are looking at the brain by imaging studies. For example, we can measure A beta 42 in CSF or plasma. We can measure phospho-tau epitopes in CSF or plasma, and we can do amyloid PET imaging. Less specific to Alzheimer's disease are other tau isoforms and tau PET imaging. And then we'll have other biomarkers of neuronal injury, such as neurofilament light in CSF or plasma, or glial fibrillary associated protein as a marker of inflammation, particularly glial inflammation. And then we have imaging markers of neurodegeneration, which is loss of brain volume on MRI or atrophy, and then glucose PET scan. And then there are other markers of vascular injury and alpha-synuclein for the Lewy body dementia. And this is when the biomarkers become abnormal. So this is abnormality of a particular biomarker as a function of time or age. And the first biomarker to become abnormal is amyloid. And so we've developed this amyloid cascade hypothesis. So this is decreased CSF and plasma A beta 42 and increased amyloid by PET imaging. This is followed by tau PET imaging in the medial temporal lobe. And then this spreads to involve the neocortex and the rest of the brain with tau uptake. This leads to neurodegeneration and cognitive decline. And then there are things that can shift the curve to the left, and these are co-pathologies or other pathologies, which can lead to these biomarkers becoming abnormal at a younger age. For example, traumatic brain injury would be one example, or perhaps having another neurodegenerative disease. For example, you can have Lewy body disease and Alzheimer's disease coexisting. And then there are things that can shift the curves to the right. And so, for example, cognitive reserve. So these are things like high intelligence and high education, where if you have more cognitive reserve, you can tolerate greater burden of pathology without causing cognitive and functional decline. So there's some features that overlap with HAND and AD. HAND may affect 30 to 50% of HIV positive individuals, Alzheimer's 10% of 65 plus, or maybe 2 to 5% at 65, and then doubles every 5 years after that as a function of age. Risk factors, age, lower CD4 T cell counts, higher viral load, co-infection, substance abuse. Risk factors for Alzheimer's, again, age, ApoE4, genotype, traumatic brain injury, hypertension, diabetes. Pathogenesis, the HIV doesn't directly infect neurons in the brain, but it does infect glial cells, particularly microglial cells, which are the phagocytes in the brain, which could leave and re-enter the brain as macrophages. So HIV does affect glial cells in the brain and causes inflammation. There's also a proposed mechanism of toxic HIV proteins affecting neuronal function. In Alzheimer's disease, it's the accumulation of this amyloid and tau as protein aggregates, and as well as neuroinflammation. So this neuroinflammation is sort of one of the common pathologies seen in both. As far as biomarkers of HAND, I don't know if there's anything truly specific or diagnostic as yet with HAND, but these are proposed biomarkers, and we clearly have definite biomarkers for Alzheimer's disease that have been developed, and only 2 weeks ago, our first plasma biomarker was FDA approved, which is a ratio of A beta 42 to phospho-tau 217. So now we have plasma and CSF biomarkers of the disease of Alzheimer's. On imaging, there's atrophy and white matter changes, which can be seen just with normal aging and also with Alzheimer's, so nothing really specific there. But the glucose PET scan has a particularly abnormal signature, which is relatively diagnostic of Alzheimer's disease. And then, of course, amyloid and tau pathology can also be seen by injecting a ligand that binds to the amyloid plaques or the tau tangles. So you can see these pathologies directly now by PET imaging. So all of these biomarkers have been useful in the Alzheimer world to help with diagnosis, prognosis, testing new drugs for efficacy, etc. As far as clinical presentation, the art has sort of shifted the dementia or cognitive decline of HIV to a more cortical presentation, which is very similar to that seen with Alzheimer's disease, gradual and progressive decline. But with HAND, patients may actually improve if their compliance or treatment with art is more effective, whereas we usually don't see improvement with any Alzheimer's patients. The pathogen in HAND is, of course, HIV, and the pathogen in Alzheimer's is thought to be this accumulation of amyloid and tau pathologies in the brain, both with chronic immune activation, microglial activation in particular, but also astrocytic activation in Alzheimer's disease. No specific hallmark of HAND, but definitely diagnostic biomarkers of Alzheimer's disease. Brain regions, basal ganglia, frontal cortex, and hippocampus, temporal cortex for Alzheimer's, but still a lot of overlap. Shared pathophysiologic mechanisms include this chronic neuroinflammatory state, which could contribute to the cognitive deficits, synaptic dysfunction, mitochondrial damage, blood-brain barrier disruption, causing overlapping neurocognitive symptoms. And so now we have this diagnostic challenge. Is it HAND? Is it HIV? Is it Alzheimer's? Is it both? Does one contribute towards the other or not? They do certainly share lots of cognitive symptoms, and older individuals with HIV may increasingly develop HAND and perhaps Alzheimer's disease as well. But the clinical criteria, if we apply them strictly, are really mutually exclusive. So, according to if you apply these criteria strictly, you cannot possibly have both, because the criteria rule out one diagnosis if you have another dementing diagnosis. And the imaging of fluid biomarkers, however, have sort of helped us in the Alzheimer field in coming to the rescue and allowing us to diagnose Alzheimer's in patients who have HAND. As far as treatment, basically treat for both. So the treatment of HAND is optimize art and perhaps consider switching or treating with art that has the best penetration of the blood-brain barrier to get into the brain. So the brain is somewhat privileged, so the HIV could still have somewhat free reign, even though there's no detectable HIV in blood. Lifestyle modifications, management of comorbidities. With the treatment of MCI and Alzheimer's is cholinesterase inhibitors to support the neurotransmitter acetylcholine, NMDA receptor antagonist to block excitotoxic neuronal death, lifestyle modifications. And now in the last 2 years, we have 2 anti-amyloid monoclonal antibodies, which are effective in removing amyloid from the brain after given IV for several months or years. And the impact of removing amyloid from the brain means that there's a slowing of the cognitive decline. And so while one antibody was approved in 2023, one was approved, FDA approved 2024. And so these are effective and approved for patients with MCI or mild dementia due to Alzheimer's. So one problem, of course, is that the HAND patients may also have Alzheimer's, but diagnostic delay may lead them to only find this out after they're beyond the mild stage, when they may no longer be eligible for these anti-amyloid antibodies. As far as epidemiologic considerations, the HIV population is aging, and so getting within the striking range of MCI and Alzheimer's disease and other dementing diagnoses, of course. So we really need more longitudinal studies on HIV and aging. Maybe HAND or HIV accelerates age-related neurodegeneration and Alzheimer's disease, but we don't know. This is a working hypothesis. And one problem that we have in our field is that we typically exclude anyone who's HIV positive because we want a pure diagnosis to see if a drug is effective for MCI or Alzheimer's disease. So, there's very little work done with older HIV individuals, and all of the Alzheimer's research excludes these individuals. And then there's a question of the HIV versus the question of the drug treatment for HIV on the aging brain. Does the virus cause issues, or does the drug cause issues, or do both of them impact the brain? Is there an interaction between amyloid deposition and HIV inflammation? Is there a role for Alzheimer biomarkers in HIV-positive older individuals? And as I mentioned, there's a newly approved FDA plasma biomarker test, which is now available. And this is from Fujiri Biodiagnostics or LabCorp, and this measures the p-tau217 to A-beta42 ratio as a helpful diagnostic test. And there's also recent studies looking at the impact of the HIV drugs on risk of Alzheimer's disease. So here's an example of a study. This is an epidemiologic study. So take it with a grain of salt, but these were people exposed to NRTIs, reverse transcriptase inhibitors, versus unexposed. And this is showing a bit of a protective effect of NRTI use on reduced risk of Alzheimer's disease. So, so this is intriguing. You know, we don't really know if this is true or not. This is epidemiologic data, but the other result with this study is that none of the other categories of HIV drugs showed this effect. So it was only the NRTIs that showed this sort of protective effect, about 10% reduced risk of Alzheimer's disease if someone was taking NRTIs. And this is two different populations, two different ways to analyze the data. So here we have now a protective effect of the NRTIs in Alzheimer's disease. So since the introduction of ART, HIV, of course, has become a manageable chronic disorder, and more people are reaching older age groups, the geriatric age group, and thus at risk of Alzheimer's and other neurodegenerative disorders. About 30 to 50% of HIV individuals will develop cognitive disorders, which is called HAND. Alzheimer's disease biomarkers have not been systematically examined in older individuals with HIV and HAND. And our patient was actually the first patient in the world that was HIV positive with a positive amyloid PET scan. And so we thought this individual had both HAND and Alzheimer's disease, and we had evidence for both pathologies impacting the brain, particularly from the glucose PET and the amyloid PET and the spinal fluid results. Since then, there have been other cases, of course, but we sort of have a problem in that our criteria won't allow the diagnosis of one if you have the other. So it is complex and a difficult question, and still an unanswered question. But chronic HIV infection does not preclude amyloid deposition, as seen in our case, and individuals with HIV can certainly develop cognitive decline due to HAND or Alzheimer's disease, or both. And amyloid PET imaging can help distinguish HIV-associated pathology from amyloid deposition in demented individuals. And anti-amyloid antibodies for early Alzheimer's may be effective in those who are HIV positive with HAND and Alzheimer's disease. But of course, to my knowledge, no HIV positive individual with Alzheimer's has received these antibodies so far. At least there's nothing in the literature. So here's some references about some of the work that I described. As I mentioned, it's still an unanswered question. And I'll just leave you with a search that I did in clinicaltrials.gov. And I entered search terms Alzheimer's disease and HIV. And here is a small pilot study looking at the NRTIs as a possible treatment for Alzheimer's disease, with the hypothesis that there may be some anti-inflammatory effect of the NRTI in Alzheimer's disease. So because of the promising data, such as that epidemiologic data, there are efforts underway to see if these drugs may be useful in the treatment of early Alzheimer's disease. So I hopefully have left lots of time for questions and discussion. And please scan this and complete the evaluation. And I haven't looked in the chat, but if there are any questions in the chat, we can address those. Anyone have any questions while we look at this?
Yes, we have one question. from Grace Rutha, who asks, would someone with mild ANI, MND in hand go effectively on disability?
I would think so. It depends on which disability. Is it Social Security disability, or is it, all the other private disability policies? They all have their own criteria. But certainly cognitive impairments can, lead to not being able to do your job, such as my patient that I published, and so could qualify for disability.
Thank you. And I see somebody else has their hand raised. If you could just put your question either in the chat or in the Q&A instead of raising your hand, we will be able to address it.
And if anyone wants the slide deck, you're welcome to have it and use it as you wish.
Yeah, I'm going to give them a couple seconds to announce their question in the chat or in the Q&A because they lowered their hand. What is the best way we as clinicians can prevent patients with HIV progress into hand?
That's a great question. I think based on what we know so far, getting ART treatment early and good compliance with ART, and avoiding as much as possible all comorbidities, such as other things like traumatic brain injury, drug abuse, treating hypertension, diabetes, et cetera, et cetera. So all of those things may protect someone from getting hand if they have HIV positive, if they're HIV positive.
Thank you. Are there any more questions? Oh, all my uncles from my father's side have had Alzheimer's. Should I check for any genetic tests?
There is a genetic test available. You can get your own ApoE genetic testing done privately from companies such as 23andMe, and keep it private so it's not in your medical records. The only risk of getting the ApoE genetic testing is perhaps insurability. Not for health insurance, because that would be illegal, but definitely possible for life insurance, disability insurance, long-term care insurance. You can find out your genetic risk by yourself, or with your clinician, your primary care provider, if you wish. But there is that risk of insurability if the information somehow got to the insurance company.
Thank you. Okay. How would case managers be able to advocate for clients who may be exhibiting hand?
Well, I guess you'd want to have sort of good documentation of the diagnosis. Perhaps not just cognitive assessment, but neuropsychological assessment. We often get a neuropsychological test battery when there are legal issues or when there are benefits issues. It sort of helps prove the diagnosis to whoever needs proof of the diagnosis, and then use that to advocate for your patients.
Thank you. What is known about the use of lithium to prevent the accumulation of protein?
Yeah, we've tried lithium for Alzheimer's. The problem is lithium has side effects, and I think it's still being tried. There's probably still one trial ongoing looking at lithium as a treatment or prevention of Alzheimer's disease. We don't have evidence yet that it's helpful. There's theoretical benefit, but it also has not a particularly good safety profile. The toxic dose is not very far from the effective dose, and one of the side effects is tremor. So people can have a lithium tremor. So it's being investigated, but we have no evidence yet that that I would recommend it.
Thank you so much. And for everybody asking about a copy of the slides, there's going to be a copy right now in the comments, and we'll also follow up with an email with a copy of the slides. If that's it, and there's no more questions.
One person said, I'm pessimistic about how NRTIs were shown to be beneficial. Sounds like an art effect. Yeah, this is epidemiologic data, so it's not the gold standard, which is a placebo-controlled double-blind study. So I'm also a little bit wondering about how that might work or how it might be effective. But there is that one pilot study underway, so we'll see what the results of that show. But what's interesting is that it was only this one class of art that decreased risk of Alzheimer's, but not the other classes. So I don't know if there's something special or different about this class that could be helpful in the Alzheimer world, but it's being pursued somewhat. Is the cornerstone of most art regimens. Yes, right. So maybe there just weren't enough patients in the other groups to really have enough power to see an effect.
We have one more question in the Q&A. Are there any links to clinical trials we could participate in?
Yes, I would go to clinicaltrials.gov and you can enter search terms as you wish, and you can enter geographic location as you wish. And all the clinical trials in the United States have to be registered at clinicaltrials.gov. It is searchable, as I mentioned, and it has contact information. So if you find a study of interest, you could call or contact the persons listed on that website. And there are lots of studies looking for volunteers in the Alzheimer world, but also in the HIV world, and basically in any medical research field. We're always desperate for volunteers to join trials, and this is probably the best way to find it.
All right, that link has been added to the chat for anybody who needs it, clinicaltrials.gov. Moises, would you like to wrap us up?
Sure. I want to thank Dr. Turner. It has been a great presentation and a good questions also from the audience that have brought us to think about how we work with ourselves in terms of like being aware of what to look for or what to ask our doctors, but also as we work with other peers that we can provide some help and support and information. I think knowledge is power. And as we move towards surviving and living longer, these kind of webinars and this kind of clinical information is very useful. So thank you, Dr. Turner. Thank you to the DC CFAR for collaborate with us in putting this webinar given to you. And I look forward for the next presentation. And thank you again, Dr. Turner. Probably will bring you back in 6 months for an update. Thank you, Brandy. Thank you.
Thank you.
DC CFAR. Thank you, Ter.
Thanks, everyone.
Bye-bye.